Morning, everyone. Unfortunately, I couldn't be there with you in Cape Town. Also, sadly, I couldn't make the time slot to be with you live. I did record my talk, and I also have some cases which I've shared with Koos, and maybe you guys can go through that later. But thank you to Smith & Nephew, and thank you to Koos for having me here. I was going to jump right to it. I'm sure Mark has wowed you with his talk on the diagnosis of infected total hip arthroplasty. So I'm going to run through some of the management options you can look at for an infected total hip. Just who I am, who is this fellow from across the country. I completed my training at in Pretoria, Tux in 2018. I did a fellowship with Koos 2019, 2020. I then I had to do another fellowship by going to Canada in 2020, 2021. I returned last year of August, and I've been in full-time private practice since September 2021 as my solo private practice. So when we think about the management of an infected total hip arthroplasty, probably one of the most important things we look at is how acute or how chronic is this infection. We generally sort of ballpark look at it, is it less than or more than 4 weeks after surgery, or in a hematogenous infection from somewhere else in the body, from a well-functioning, previously well-functioning total hip arthroplasty, is it less than 3 weeks or more than 3 weeks of symptoms? And also the way it presents is usually quite different as opposed to the acute one, where it presents with an acute sort of typical septic arthritis type of picture versus the chronic, who presents with sometimes with sinus tracts, etc. The bacteria you're going to find is usually quite different. And then the way you're going to treat it, or your treatment options you're going to consider, are also very different. So what are we looking at? So we've already mentioned acute post-operative infection, acute hematogenous, and then chronic infection. And there's also that I think we all kind of dread, is that we do an aseptic revision. We're always trained to take cultures. We've done the revisions, patients doing relatively well, and then we get a positive culture. So there's two things we need to ask ourselves when we're treating a infected total hip arthroplasty. And the first question is, are we going to retain the prosthesis? So if we're going to retain the prosthesis, then we're looking at something called a DARE, so a debridement and implant retention. And if you're going to remove the prosthesis, we need to look at, are we going to do this in one sitting, so a single stage revision, or are we looking at doing this in a two-stage revision? All right. And in general, your success rate is directly compared with your length of time, which is what we've been through just previously. And the second thing is, how virulent is this bacteria, and what's its biofilm activity? I'm sure most of you have a good idea what a biofilm is. I'm not going to go into that. Just another thing, when we're talking about revision total hip arthroplasty, you're usually dealing with quite ill patients. They have medical comorbidities. You're dealing with microbiology, antibiotics, etc. And it's important to have a good multidisciplinary team, whether you're working in state or working in private. You need to put together people who are like-minded and who you have open communication channels with. And this usually involves an orthopedic surgeon, plastic surgeon, microbiology physician, and sometimes also an infectious disease specialist. The next thing to remember is, when we're talking about, implant retention or changing of the implants, the one thing that remains constant and of utmost importance is the quality of your debridement. Your debridement needs to be systematic, not systemic. It needs to be thorough, and it needs to be extensive. You need to go and remove all of that infected and dead tissue, whether it be soft tissue or bone, in your first debridement. You always hear that, when you're training in Pretoria, that the solution to pollution is dilution. So when you're washing out after your debridement, it needs to be copious, it needs to be very thorough, and it needs to be chemical. What we would use is 3 liters of iodine, 3 liters of peroxide, and then 3 liters of saline as well. So what we used to call triple wash. So that will remain constant, irrespective of the the way you're going to deal with this infection. All right. Just to mention non-operative treatment, because I've just only mentioned operative treatment, there are some situations where a patient is medically unfit and the treatment itself is likely to kill the patient. In this patient, you can consider chronic suppressive antibiotic therapy. And what we would normally use is Bactrim, but just also warn your patients about the risk of Stevens-Johnson syndrome with long-term use of Bactrim. However, your antibiotics can be tailored to whatever organism you have cultured or you think may be the culprit. Bactrim is usually well tolerated in the long term. So first looking at the DARE, so the debridement and implant retention. And this is only an option in patients with an acute or acute hematogenous infection. And what this involves is a modular component exchange. So what do we mean by that? The heads and the liners of our total arthroplasties are what the modular components are. We know more, I don't think anybody uses modular necks anymore, but definitely the head and the liner in most cases is your modular component. And the reason why we need to change these modular components, not just routine, is that bugs and necrotic tissue, septic tissue can get lodged between the head and the trunnion, or between the liner and the cup itself, which is important to get that out so you're able to do an adequate debridement. The second thing, as we mentioned before, is your debridement, so removal of all infected and necrotic tissue, and to do a thorough synovectomy, and then again irrigation. And then you need to look at doing 4 to 6 weeks of biofilm active antibiotics to treat this infection. There's another thing to consider is that, if it's an acute infection and you haven't had ingrowth into the uncemented implants, if you use uncemented implants, you can still consider an exchange of the implants because it's relatively easy to take out in most cases. But then you ask yourself, is this still really a DARE or is it not? The important thing is that success of this depends on early intervention. So we're looking at, some studies say, less than 48 hours of the onset of symptoms. But it's definitely something to consider in your acute infections in the right patients. Your director, your one-stage revision, which means that you go in, you remove all the components and you immediately re-implant with your definitive components, is what you call a one-stage revision. Not very popular in some circles, but more popular in others. And I think the important thing here is your patient selection. So you need to have a healthy patient. You need to know which microbe you're treating, such as a gram-positive bacteria, where you know that you have a sensitive antibiotic or sensitive bug with a sensitive antibiotic. Obviously, you cannot do this in the setting of a draining sinus. This is not possible. And then here again, we stress that this needs to be a meticulous debridement. And then when you re-implant, you need to re-implant with antibiotic-loaded cement. And then again, after that, you need to continue with at least 6 weeks of antibiotics, if not more. Some studies have looked at sustained antibiotic therapy, so SAT, more than 1 year. There isn't enough data to suggest that we should do this routinely. Suffice to say that we need to also balance this against the effect of, these patients are already frail, they've already dealt with the hit of an infection and then surgery. Sometimes they don't respond very well to the side effects of the antibiotics. The reason why this has become popular as opposed to our traditional two-stage is that it's significantly less cost, it's less mobility to the patient. And there is a relatively higher rate of mortality associated with two-stage revisions, whether this is due to the two-stage revision itself or due to the fact that these patients who need two-stage revisions are generally more sicker. We're not too sure yet. I mentioned that you probably want to put in a cemented prosthesis. However, there is a multi-center randomized control study underway looking at the differences between either uncemented or cemented implants. I personally would use a cemented implant. It just allows me to get much more local antibiotics. As I mentioned before, if you're considering doing a DARE procedure and replacing the non-osteo-integrated components, it doesn't technically stay a DARE anymore. This could be considered a one-stage revision. Another way which can guide your debridement is methylene blue guided debridement. and gives you good visual control of the surgical debridement. Personally, I haven't seen it been done before, but I did have colleagues from other countries who had used this with good success. So the traditional or the delayed or two-stage exchange typically involves your first stage where you go in, you do your debridement, you wash out, you remove all the components, and then you put in a temporary spacer. We'll discuss spacers a bit later on. But the concept is that you leave in a spacer and give the patient antibiotics, give them some time to let the infection settle, and you go back and you replace your component at a second stage. Or sometimes, in very bad cases, sometimes even a third stage where a patient needs more than one debridement. And I think for now, this remains the standard for chronic infection, where you remove all the components. And this is important to remember, you remove all the cement as well. Again, we're stressing on debridement. The spaces can be articulating or they can be static. And typically, we look at 4 grams of antibiotics per 40 grams of cement. We would always try and add a vancomycin and a knee glycoside. Most of the cement nowadays come with gentamicin, so it's just a matter of adding the vanco. Adding more antibiotics to your cement is going to weaken your cement too much, so we wouldn't go more than that. And then again, we look at 6 weeks of antibiotics. I'm giving you sort of ballpark figures for the durations of antibiotics. We will come to look at duration of antibiotics slightly later on in this short talk. So some studies may suggest that, look at reinfection rates of 2-stage versus 1-stage. And for certain patients, 2-stage might be a bit of an overkill in patients who fulfill the criteria for a single stage. So we haven't quite got it figured out yet which patients would be the candidates or definite candidates for 1-stage or 2-stage. I think that the jury is still out there. But definitely when it comes to 2-stage revisions, you're looking at much higher morbidity, longer hospital stays, and longer time of immobilization, and deterioration of functional outcomes, and overall higher healthcare costs, which is definitely something that's a hot topic, especially in the private sector. So the next question is what's the time frame for reimplantation? And this is variable. Some people would just look at going in at 6 weeks, some people with 3 months, some people 6 months, some people would culture first, some people don't. There's a lot of variation in the way different units do this or different individuals do this. So this would largely depend on where you train and what you feel comfortable with. There was a concept of antibiotic holiday and a repeat aspiration. This has kind of fallen out of favor. We don't look at it, we continue antibiotics till after the second surgery. We don't have a gap in between. And always is that debate between the cemented or uncemented prosthesis. And that also the jury is still out there. I did mention 3-stage or multi-stage revisions, and these are patients with prolonged wound discharge after initial debridement and explantation or persistent signs of infection despite sufficient local and systematic antimicrobial treatment. So it's either the patient actually needs this debridement, or maybe the debridement wasn't adequate in the first place. Also depends on the bug. We don't really know. But don't be too rigid in the sense of I've done my first stage, irrespective of the patient. I'm going to go ahead with my second stage. If the patient needs more than one debridement, go and debride, go and get rid of the infection before you go and reimplant. So this is a treatment algorithm from a recent E4 review. And the important things they've raised here says, is it a DTT bug? So is it a difficult to treat infection? And what do they mean by this? Is it a bug that's resistant to biofilm active antimicrobials? And we'll touch on rifampicin and its biofilm activity a little later on. Also, other ones looking at is ciprofloxacin resistant gram-negative bacteria. The ciprofloxacin is definitely one of those oral antibiotics that you can continue once you stop your intravenous antibiotics. Or is this a fungal infection? Also very rare, but definitely enough cases in the literature to get us a bit excited about. It definitely is. It does exist, especially in your culture negative, difficult to treat cases. You need to always consider, is this a fungal infection, especially in your immune compromised patients. But this is a nice little flow diagram, which kind of summarizes much of what we've discussed above. Also touches on intervals between first and second stage, and also antibiotic duration. So then antibiotics, right? So I think most of us will agree that you start your antibiotics after your debridement. So after you've taken your cultures, most of us will take the cultures, and then we would ask our anesthetists to administer the antibiotics. For multiple reasons. Firstly, we don't want the antibiotics to affect our cultures that we're going to take. The second thing is that we want to decrease the bacterial load before we start antibiotics. Also, just a mention about taking cultures. We don't take one culture or two cultures or three cultures. I think most guys will go for about 5, 7, or 9 cultures. And we always try and go to an odd number so that if you grow 2 different organisms, you can see which one is predominant, and you at least have a clear winner if you take an odd number. The important thing is also to de-escalate your antibiotics as soon as possible to the bug that you grow, and not keep the patient on too broad a spectrum antibiotics to prevent resistance. And we generally look at IV antibiotics for at least 14 days. For your staffs, if you're going strips, you may look at wanting to continue it for 21 to 28 days. And then you switch to oral after this. Things would help you switch to oral is that if you have an oral one that has good bone penetration, this is where your infectious disease doctors can definitely assist you in guiding antibiotic choice. We generally want to switch after the wounds are relatively dry and healed. You see your CRP is coming down or at least near normal. As I mentioned before, we don't think about or don't do antibiotic holidays anymore. If we're staging it, we continue antibiotic still implantation, and it is afterwards for 6 weeks. And then if your culture at your second stage revision was positive, then you should continue at least for 12 weeks. And then again, which antibiotics are we using, right? And this also depends on institution, local factors, local sensitivities. Again, this is where your infectious disease team can really advise you on what's been growing in their labs and what are the common bugs that you find in your institution and in your area. But generally, as a principle, this needs to be broad spectrum. Combinations that are commonly used is vancomycin and meropenem, or rifampicin and ciprobe. Rifampicin is a great drug. It has the ability to penetrate bacterial biofilm and potentially important adjunct in the treatment of periprosthetic joint infection. There was a recent systematic review and meta-analysis by Cruz et al. At University of Toronto, and they found a protective effect against treatment failure when you use rifampicin following prosthetic joint infection. But importantly, this doesn't apply in your DARE procedures. This only applies in your 2-stage or multi-stage procedures. So in the DARE procedure, not much of benefit from rifampicin, but if you're doing multi or traditional gold standard 2-stage procedures, then rifampicin can be an important adjunct. Still further studies needed. I did say we would touch again on duration of antibiotics. I found this was a great sort of summary. I used to always ask myself, how long do you continue with the antibiotics? So in this paper, they looked at the type of surgery that you're doing and kind of given advice of how long you should continue antibiotics. And ballpark, you're kind of looking at about 12 weeks of total antibiotics, both IV and then oral. So if you're looking at retention of your well-fixed components of your DARE procedures, you're looking IV for 2 weeks and then follow up with 10 weeks of oral. If you're doing your 1-stage, you can do just exactly the same, 2 weeks of IV and then 10 weeks of oral. If you're doing your 2-week exchanges with short intervals, so bug that you can treat well, then also it's about 3 weeks total of IV antibiotics and then 9 weeks of oral. If you're doing your typical long interval, then you're looking at about 2 weeks of oral, 4 weeks, 2 weeks of IV, 4 weeks of oral, another week of IV, and then 5 weeks of oral. And if you're 3-stage or multi-stage, you're going to kind of tailor that, basically IV till until after your final implantation, and then another 5 weeks of oral. So maybe get hold of that paper, and then you'll have a pretty good overview of the current treatment options, especially when you're looking at antibiotics. This is not very commonly done, but this essentially what we're talking about is when you're doing a revision, and talking about in the setting of a chronic infection, where you selectively retain an implant, knowing that this is a chronic infection. And there's very, very few papers which actually look at this. I was fortunate, Jeffrey Gollish was one of our supervisors in the University of Toronto, and he's done a number of patients like this, where he has left well-fixed implants in chronically infected hips, and then managed to successfully treat the infection with just isolated exchange of certain components. But it's important to understand why, what the reasoning behind this is. So you need a couple of prerequisites, I could say. So firstly, the patient needs to be immune competent, relatively healthy patient, and needs to be a bug that has good penetration with antibiotics, or you have an antibiotic which you can treat this patient successfully with. Second thing, obviously, similar to a 1-stage, you cannot do this in a patient with a draining sinus. Thirdly, you need to have the femur, which is in most cases the retained implant, needs to be well fixed. And the reason being is that if you go back to particle disease, we look at the effective joint space. So normally the joint space is just between the top part of the femur and the rim of the acetabular cup. However, once these particles get between the implant and the bone, that becomes the effective joint space. So technically speaking, if you have a well-fixed implant, there's actually no portal of entry for the bugs to get between the femoral prosthesis and the bone. Therefore, if you just, you debride thoroughly and you wash the prosthesis proximally, and there's no seeding infection down the femoral shaft, technically that's not involved in the effective joint space and not involved in the infection. So what you would do, what you can consider in this situation, and to avoid destroying the femur by taking out this prosthesis, is to open up the hip, remove the acetabular components, again, do a thorough debridement, thorough washout, and either as a single stage, replace the acetabular component, or as a second, you do it in a 2-stage where you put in a ball of cement, you come back at a later stage and then replace the acetabular component without actually changing the femoral component. The indications for this is relatively slim, and the chance of actually doing a widespread study or randomized control study on this is also relatively slim. So I would only look at this in in a very highly experienced surgeon or highly selective cases. But there is some talk about it, so definitely something to consider and something to keep out or look out for in the literature to come. Just a mention on spaces. I did mention them before. You can have either articulating or you can have static spaces. So on the right, you see, extensive bone loss from infected total hip arthroplasty. Definitely not a candidate for an articulating spacer. Here you have a cement ball inserted into the defect, and then you have a cement put down the shaft as well. This is an example of a non-articulating spacer. Articulated spacers can be 2 different types, either completely cement type spacer, basically cement shaped into the shape of a hip prosthesis, or you can look at I think what's more commonly done is a poorly cemented implant, so a cemented cup and a cemented stem, which hasn't been cemented in 100% to make it easier to explant and put in definitive prosthesis. I've tried to include examples of these in the cases as well. I'm sure Kouas and the other guys will recognize some of the cases. Some of the cases are not from Tigerberg. But the reason why I think articulating spaces are definitely the way to go, if possible, is that it reduces your hospital stays. Patients have higher hip scores. They have much better function before their second stages, much shorter surgical times for the second stage, and less blood loss at reimplantation. So if at all possible, always try and use a articulating spacer. So that's all it from me. I have included the cases. I'm sure Kuas or one of the other guys will take it upon themselves to go through them. Some are definitely my own, sadly, and some, thankfully, some of them are others, so not all mine. I attempted to show a variety of treatment modalities, as mentioned before. And when looking at the outcomes or stages, things that come to mind, there's more than one way to skin a cat. And as a colleague of mine always says, everybody kisses his wife is one way. So the way that we've shown the case was treated may not be right in your eyes, or you may want to do it a different way. So definitely, go ahead and have the discussion. And if you disagree, do that. That's completely fine. However, enjoy the cases, enjoy the rest of the course, and I hope to see some of you or many of you at the next Congress or next meeting. If you'd like to get in touch with me, my email is surgery@drmanjra.co.za. It'd be great to connect and share cases and get to know everybody. Take care and all the best.